Hello guys, welcome back to Clinically Clear. Today we'll be covering a few important corneal surgeries. Just the singy questions, not everything, just the singy questions. So let's start with keratoplasty, 5 mark question. Okay. So what is keratoplasty? It is corneal transplantation. So what are we doing? We're taking a healthy corneal graft and we're replacing the diseased cornea. So diseased cornea replaced by a healthy corneal graft. Types: autokeratoplasty, allokeratoplasty. Autokeratoplasty from diseased persons, from the diseased person's cornea only, from the other eye, or let's say what it is, basically from the same individual. I'm sorry for butchering that. Basically, the corneal graft is from the same individual. Okay, it is given to the same individual, it is obtained from the same individual. Allokeratoplasty, the donor graft is from a, basically you use a donor recipient corneal graft to replace the you use a donor healthy graft to replace the diseased recipient corneal graft. I don't know why. Okay. Then rotate. Let's look at the types of autokeratoplasty. We have rotational keratoplasty and contralateral keratoplasty. See, rotational keratoplasty, what do? We just rotate the diseased cornea, just orient it in such a way that the corneal opacity that was normally in the center is now moved to the periphery, so that there is less vision loss. So rotational keratoplasty. We haven't even excised the cornea, nothing. Contralateral keratoplasty is the second type of autokeratoplasty. Basically, let's assume one eye has a healthy cornea, but that eye is blind because of some posterior segment disease, some retina problem, something like that. That eye is blind, but it has a healthy cornea. The other eye, patient was able to see it, but now patient has a corneal opacity, patient has a diseased cornea. So if we just exchange, then it becomes contralateral keratoplasty. This eye will have healthy posterior segment, healthy cornea. This blind eye, anyways, let it have the diseased cornea, no problem. So that is contralateral keratoplasty. Rotational keratoplasty, contralateral keratoplasty. These two come under autokeratoplasty. Now, allokeratoplasty can be of three types. First, let's look at penetrating keratoplasty. Basically, full thickness is replaced. The recipient corneal graft, full thickness removed, and donor full thickness corneal graft is given. Penetrating keratoplasty, what are the indications? Optical indications, basically to improve the vision, to give the patient vision. Patient has a corneal opacity. Patient has corneal edema. Patient has bullous keratopathy. Patient has keratoconus. Conditions where the cornea is so diseased that patient is not able to see. So we'll give a corneal transplant so that optical indication, patient is now able to see. Then cosmetic indication, patient wants to improve their appearance. I don't know how a corneal transplant will really benefit, but patient wants to improve their appearance. Then tectonic indication, basically to maintain the integrity of the eyeball. If there is any corneal perforation, the eyeball integrity is compromised, right? It is no longer a globe, there is a perforation. So to maintain the integrity of the eyeball, tectonic indication, that is, like example is corneal perforation. Then you also have this thing, therapeutic indication. For example, patient has fungal corneal ulcer or any corneal ulcer which is not healing, non-healing ulcer. Whatever you give it is not healing. You do surgical debridement, nothing, it's not healing. So then it goes for therapeutic indication. So this is about what? Penetrating keratoplasty, that is complete thickness. Lamellar keratoplasty is when you put a partial thickness corneal graft. It can be anterior lamellar keratoplasty, it can be posterior lamellar keratoplasty. Anterior lamellar keratoplasty is done if the Descemet's membrane and the endothelium is intact. Posterior lamellar keratoplasty, also known as endothelial keratoplasty, it is done when only the endothelium is diseased. Only the endothelium has some problem. So then we'll only replace the posterior lamella. That is why it is known as endothelial keratoplasty. What are the indications? Pseudophakic corneal edema, aphakic corneal edema, Fuchs endothelial dystrophy, posterior polymorphous dystrophy, etc. So some indications. Remember 3 or 4. 4, just in case you forget one in the exam for a 3 marker. So pseudophakic corneal edema, aphakic corneal edema, Fuchs endothelial dystrophy, and posterior polymorphous dystrophy. So this is about endothelial keratoplasty, partial thickness graft of posterior lamella, comes under lamellar keratoplasty. Third type is small patch graft, basically just a small patch of the cornea. You're not removing one whole cornea and then putting a new cornea, just a small patch of graft. So penetrating keratoplasty, full thickness, optical indication, tectonic indication, cosmetic indication, therapeutic indication. Lamellar keratoplasty can be anterior lamellar keratoplasty or posterior lamellar keratoplasty. And then you have small patch graft, where just a patch of the cornea is replaced. Now, what are the steps? Steps we are assuming for an this thing, penetrating keratoplasty, just a complete penetrating keratoplasty, full thickness. First, you will excise the donor cornea. So the donor corneal button, they say, should be 0.25 centimeter more than the recipient's corneal bed. That is one thing. And when you are excising it using a corneal trephine, you should be very careful not to damage the endothelium of the donor corneal graft, donor corneal button. So you remove the donor corneal button. Then next step, we excise the recipient corneal button. We can't just put it over the recipient's cornea, right? So this is done using a corneoscleral scissor, excision of the recipient corneal button. Then we just suture the donor corneal button onto the recipient's corneal bed using nylon sutures. Simple 3 steps. Excise the donor corneal button. Make sure not to damage the corneal endothelium. Use a corneal trephine, 0.25 centimeter bigger. Excise the recipient corneal button using corneoscleral scissors. Suture the donor corneal button onto the corneal bed of the recipient. And then what could be the complications? The complications could be immediate complications like infection, or it could be any anterior chamber flattening, it could be iris prolapse, or it could be late complications like astigmatism, it could be any graft rejection, which is a chronic type 4 hypersensitivity reaction. And this graft rejection also, it need not be that the entire graft is being rejected. A single layer of the cornea also can get rejected, like epithelial graft rejection, endothelial graft rejection. So different types are there. So immediate complications: infection, anterior chamber flattening, iris prolapse. Late complications like astigmatism and graft rejection. This is about keratoplasty or corneal transplantation. Then coming to refractive corneal surgeries. In this, first of all, 3 marker they can ask, name 3 refractive corneal surgeries. For that, you have radial keratotomy, you have LASIK, that is laser assisted in situ keratomileusis, and you have 2 other ones, that is C for photorefractive keratotomy and astigmatic keratotomy. Now, I've written for radial keratotomy and LASIK just 3 mark, very simple answers. I've not gone too much in detail. If you'd like to know it in detail, then please read the book. This video is not going to be of much help. Radial keratotomy is not done nowadays. It is a refractory surgery that used to be done for myopia. Basically, what they do, in the cornea, they make radial incisions, only leaving the central optical zone intact. Everywhere else, they'll make radial incision. When they make these radial incisions, eventually it will heal. When it heals, it will flatten the cornea. And when we flatten the cornea, we know that power reduces. And when power reduces, it will correct the myopia. So myopia of 2 to 6 diopters can be corrected using radial keratotomy. But why don't we do it then if it is correcting myopia? Because of high risk of complications. You're making incisions on the cornea, so the cornea has become very weak. So there's a risk of globe rupture, especially in people who can get hit by blunt trauma, like athletes, like soldiers, etc. Understood? So that is one, risk of globe rupture in radial keratotomy. And second one is uneven healing of those incisions can lead to irregular astigmatism. So globe rupture risk in athletes and soldiers and irregular astigmatism. That is the reason why we don't do this thing. That is the reason why we don't do radial keratotomy. So astigmatism due to uneven healing and risk of globe rupture. Then coming to LASIK. Now, what is LASIK? Laser assisted in situ keratomileusis. Laser assisted in situ keratomileusis is the refractory surgery of choice for myopia. So, what do we do? See, this is the cornea. Let's say this is the cornea. We just take a flap. We take a corneal flap, a partial thickness corneal flap, and then we raise it upwards such that it becomes like this. And then the stroma underneath is exposed, right? we do laser ablation of the stroma. We do laser ablation of the stroma, and then we reposition that flap. So when we reposition that flap, what happens? Cornea would have gotten flattened. So power decreases. Myopia of up to -6 diopters can be corrected. So what is it? Anteriorly corneal flap is created. Then laser ablation of the corneal stroma, reposition the flap, flattened cornea, myopia is corrected. Then what are the conditions for a LASIK? Patient has to be about 20 years old. Then patient should have a stable refractory power since 1 year. Patient should have no other corneal pathology, and patient should be well motivated. Well motivated, no corneal pathology, more than 20 years old, stable power since 1 year. What are the advantages? There is no post-op pain. There is very early recovery, no risk of globe rupture. These are all the advantages. Early recovery, no post-op pain, no risk of globe rupture. Disadvantages: LASIK is very expensive, and flap-related complications can happen. When I told you we'll take that flap, what will happen if intraoperatively this flap gets cut? Intra-op flap amputation, or after repositioning the flap gets displaced. Post-op flap dislocation, post-op flap wrinkling. Those are all flap-related complications, which are also disadvantages. So that is about LASIK, 3 marks, and radial keratotomy, 3 marks in Singi. Actually, this video, I think I was not really good at. I could just my flow wasn't there. I apologize. From next video onwards, I'll try and do better. Hopefully, you guys can bear with me till then. Thank you for watching. If you have any doubts, please let me know.